please help spread the message of frequency-specific microcurrent by clicking on the like button. You can subscribe to us on YouTube or any podcast app. If you have any questions, please leave them in the comments. You can find the podcast transcription at frequencyspecific.com, as well as more information about frequency-specific microcurrent.
Oh, I cannot hear you. Am I late today?
No,
Right on time.
you are actually, we still have 60 seconds.
Okay, I had some computer issues happening.
We had some hot tub issues. We
What?
had our annual, because we do it about once a year, right? Annual lunch and Edgefield. Those of you that come to a 5-day core or a 2-day practicum in Troutdale have the option of going to Edgefield. And Edgefield, if you rent a room there, has a lazy river 101-degree hot tub that's in like a tropical jungle plant system.
So pretty.
So in order to get paperwork done, my vacation this week was supposed to be at the beach, but instead I rented a room for 3 nights at Edgefield. So I locked myself in a room with no distractions. Excel sheets, I think, could be used as a form of torture. It should be mentioned in the Geneva Convention. And then I go in the hot, then I go for a walk, and then I do more Excel sheets. And then I go in the hot tub, and then I go home. So I sleep at home. But we had our staff meeting. So I have under this white shirt, see this white shirt, right? Under this white shirt, I have a wet bathing suit. Just saying.
That's what a great way to mix staff meetings and work in such a holistic and inspiring environment.
It's like,
You got the whole advance all planned out.
yeah, we got the advance planned out.
Perfect.
We'll see. Yeah. And the notices about doing case reports. Come on, 25 slides. You can do this. You're doing things that nobody else does and you don't even know it.
Yes.
And announcing that the American Academy of Resonance Medicine is now set up with the state of Washington as a charitable organization, and it can accept donations. We can't create memberships because that's a 504c3, or it's a 501c4 or something. So they're not memberships, but I'm going to have little pins made up for people that donate. It's got a really cool logo, and we are going to use it to fund FSM research. We practitioners don't mind collecting data and treating patients. They just don't want to write up the papers. So Candace did a great job. So I'm still going to present Candace's slides, but I've had people come out of the woodwork. It's like the universe said, oh, you want somebody to write up case reports? Oh, there are lots of people that do that. And now I have 3 people on a list who will write up any paper that we ask them to. You collect the data and somebody else will write up the paper. And American Academy of Resonance Medicine will fund imaging, will fund devices. It will fund when we get around to needing to pay for, like, you're treating somebody for free, but you need to be compensated for your clinic time. That's what the Academy does.
So cool. And if you are charting even remotely correctly, that is your data, right? You are doing pain scores before and after. You're doing range of motion before and after. That's all data. So
people just don't think of it that way.
You don't. And I remember when I went through the certification process with FSM, and part of the criteria is writing out 10 case reports. And I remember when I heard this information, whoever I was sitting next to at the advance was like, oh my God, I would never do that. And I was thinking, I've got like 20 case reports then ready to go, because
it's chart notes.
It's chart notes. And whether you're the biggest believer or the biggest skeptic, the data is there. And that's how you learn, especially in the beginning. It was always proving to myself, this is actually working. It's not just that my hope that it's working, but the range of motion is improving. And especially when you're working in a collaborative group, whether it's with a bunch of other practitioners or just referring to other practitioners, you want to show what you're doing has been effective.
Yeah. And it also helps with patients who are sensitized.
Yeah.
And they don't think anything has changed.
Sure.
And it's your pain score went from a 7 to a 3, but it still hurts. It hurts at 3, and your range of motion went from 40 to 65.
Yeah.
So it should hurt when you get to 65, or your head would fall off.
Right.
Oh, okay. So data is useful for both the practitioner and the patient.
Yes.
And then it's one of the reasons, for some reason, writing the case reports is the most difficult part. It terrifies people. And it's a soap note. You take 6 visits and you just range of motion, 1, 2, 3, 4, 5, 6. And what I treated, 1, 2, 3, 4, 5, 6. And the outcome, 1, 2, 3, 4, 5, 6. Done. And then you do visit 1, beginning, visit 6, the end. And that's a slide presentation.
Right.
I don't know. Am I oversimplifying? I don't know.
I don't think so. I think people overcomplicate it. And like you said, there's something like terrifying about that process. And maybe it's the public speaking part. I don't know, but I'm happy. I'll put it out there right now. I am happy to get up and present anybody's case or support. If that's what's preventing you from doing this, just give it to me and I'll go up there and present it. Because I don't mind that stuff at all.
And I think the other thing that is a great offer. I'm good for that. And I think it's also like PTSD from some junior high school teacher that made fun of your term paper in front of everybody.
Sure. Yes.
It's
I will take that away from everybody. Just give me the notes. I love
run concussion in Vegas and PTSD on yourself and write the damn slides.
I'll even write the slides for you. I love PowerPoints, which is why I love doing it was so funny. I had the first ever California sports hybrid this past weekend. So it's people who took the sports course, like how you were doing the practicum weekends.
Oh, yeah.
If you've taken the sports on video, like we did during COVID and certain exceptions to the rule. And so we did a practicum weekend here in Livermore. And it was so much fun because these are all local practitioners that have also been like my patients and that have taken the course or took the course and then became my patient. So I knew everybody. And it was like a giant refresher, but we had a couple new people and it was such a beautiful collaborative group of seasoned practitioners, new people. And it reminded me almost of the master class because we had a lot of freedom for troubleshooting and, hey, I have this patient who does that. And then we had a lot of PTs and a chiropractor and a holistic dentist and a massage therapist. So we got to just collaborate and troubleshoot and
mind meld.
Yeah. And we didn't even have remotely enough time. So I thought after 2 days, that would have been like more than enough time. And it really just scratches the surface. And I remember thinking when I was putting the weekend together, how much time I would spend on supine cervical and just reviewing all the stuff that we do. But it's even changed so much in the last couple of years because of the way we're questioning why.
What's causing that?
Yeah, and so it's not the B channel, it's not our location per se. And in the beginning, I have to say that was the biggest turning point was, what do you mean it's not the muscle?
I know.
There just goes my entire career.
Well, one of my patients last week was a fashionista.
Sure.
She's a myofascial therapist.
Yeah.
And so she would just hammer on the trigger points and that would make her symptoms better.
Right.
Yeah, but it didn't last because you didn't treat what's causing the trigger points.
Yes.
So she left town with the biggest smile on her face. It was awesome.
Yeah.
And the beginning of the conversion from it's the muscle to it's the cause.
Yes.
It's like her psoas and her QLs were super tight
Yeah.
with the appropriate referral patterns.
Yeah.
And oh, by the way, she had abdominal surgery for endometriosis. And it was all scarring in the uterus, scarring in the ovaries, scarring in the tubes, scarring in the bladder meant that she could urinate without pain, hold double the volume before she had to run to the bathroom.
Wow.
And her back pain went away. And we didn't do anything for the muscle. I just love being us. It's so cool.
But you did everything for the muscle, and that's part of it, right? You are absolutely affecting the fascia and the muscle by releasing the cause of why they were tight, or why they are spastic, or why they are not online, why they are inhibited, right? Yes, it's really easy for people to say you have weak glutes and you have tight hip flexors. That if I got $1 for every time somebody said that, I was diagnosed, I have weak glutes. My PT says my hip flexors are chronically shortened. Yes, you may be right on the surface. And if all you could do was smush or mash or inject and prescribe an exercise, that would be all you would look at. But that doesn't close the case on so many, or begin to scratch the surface of any true pathology.
When did your hip flexors get tight? You weren't born with them tight.
Right.
Oh, people started telling me that when I was 27. What happened when you were 20? Oh, nothing. I had a really bad kidney infection. Oh, okay. I had the coolest feedback this week.
Tell me.
There's an MD that took the class a couple of months ago, the 5-day core here. And he said, this is fourth time he's texted me. And he said, I feel like I've been let in on a secret that makes things fixable. And I said, what? And he said, the BIVSS, vestibular entries. He said, patient came in with chronic symptoms. He's been a patient for 4 years. And this time, I recognized it. I gave him the BIVS, and his score is 37/18. That's why. Prism glasses, vestibular rehab. Who knew that was a thing?
Yeah.
So I said, you give him these meds and explain his life to him, and you can send him to vestibular rehab if that's all that's available to you, and or prism glasses, for which he has to drive to Vancouver. But that section of the core, Dr. Reski is going to lecture at the Advanced again on Friday afternoon. And I keep hammering that because it's a piece that everybody misses, and only FSM practitioners know about it anymore. ENTs, neurologists, ophthalmologists have no clue.
Mm-hmm.
And FSM practitioners, I let them know the secret. It was so cool.
Yeah. And the thing is, like, you don't have to spend time rehabilitating their vestibular injuries, but it can help identify that this could be part of their life, or this could be occurring, to help lead them down the path to, like you said, there's so many different options available for them. We have a great vestibular rehab person here in the Bay Area that I love, but there's also, like you said, prism glasses. And I think it's so many FSM patients that come to us is somebody that actually listens to their symptoms and can help navigate and direct them. You're not crazy. I think this is happening. Why don't we lead you down this path and help you out this way, or whatever? I think so many patients come in just completely lost and have been dismissed so much.
And the nice thing, it's like range of motion, the BIVSS, Brain Injury Visual System Symptom Questionnaire. The BIVSS gives you a number and you explain what a vestibular injury does. You feel slightly nauseous all the time. People have been treating SIBO and IBS and GI symptoms that just actually don't exist. They're treating the nausea, but the nausea is coming from the inner ear. You have anxieties, or they're on psych meds that don't do anything for the vestibular system, but the anxiety is from the vestibular injury. And they have trouble reading, and they have this and that. And you can explain their experience, and then you have the number. So after a while of beginning to recognize it, I had one patient last week, her history was so scattered that before she finished the history, I put the BIVSS on the counter and had her fill it out. And her score was 27 out of 18. And it's okay, you're not crazy. You really don't remember things. Louise says, it's been a while since I took the core. What can cause this injury? A fall, a head injury, an airbag, an airplane flight. I have Meniere's in my right ear and possibly my left now, but it happened because my eustachian tube was plugged up on an airplane flight and the plane reached 10,000 feet and I got so dizzy, I lost my lunch and just sat in my seat with my eyes closed, and then got home, threw up twice between the car and the house, took 2 meclizines, slept for 2 hours, and I was fine. But so Meniere's is a non-traumatic form of endolymphatic hydrops, endolymphatic fistula, semicircular canal dehiscence, and you can also get a brain injury that affects the vestibular centers. And
Sports, concussions, car accidents, even a trip to Six Flags where you went a little crazy on the roller coaster.
on a day when it was raining. So low pressure is a thing. And it's the patients that say, I do fine until rainy days. Or chronic fatigue patients, and these are air quotes, chronic fatigue patients who are fine in the summer, but who are just unwell all winter long. And there's some place where it rains a lot, like the Northwest. When it rains, the air pressure is lower. So high pressure pushes the fluid back in the semicircular canals where it belongs, and your brain works pretty normal. Low pressure, that round window has got a little crack in it. Low pressure lets the fluid run out of the semicircular canals, and your balance is just off, and you feel a little bit nauseous, and you just want to lay in bed with your eyes closed.
Yeah.
And they're diagnosed with chronic fatigue because their stomach is upset. The vagus nerve doesn't work right. They have headaches because when the vestibular system is broken, the muscles in your neck tighten up to provide proprioceptive input to your brain and tell your brain where it is in space. So these people have chronic upper cervical headaches. The kind of highest concentration of proprioceptors in the body are at the occiput C1 and C2. So if you've had an injury, so if you're hypermobile or your head was turned during the fall or the accident, you have asymmetry or laxity at C1, and the upper cervical muscles just keep changing all the time. So the brain never knows where it is in space.
Right.
And that's vestibular, but it's associated with the upper cervicals.
Right.
So you have what, 4, 5 causes?
Mhm.
And they all have the same outcome. You'll all, even if you haven't had a brain injury, the BIVSS gives you an objective score. And that is helpful. That's in the resource,
It should be resource.
practitioner resources. So if you haven't been to a core in a while, you can download the slides, I think. Or I have the vestibular section of the core in the webinar section, maybe?
Yeah, in the,
Workshops, okay. So the vestibular section is in the workshops. The BIVSS is in the resource page. And you download those, update your information about vestibular injuries, how they present, what they act, what questions to ask. And then the BIVSS, you just have them circle it and then add up the numbers. And there you go. It's one of our secret weapons, but this is an MD who's been in practice for 30 years.
Mhm.
He said, I feel like I've been let in on a secret.
What a great, like you said, little nugget of feedback, right? Like you do want to leave, I want to leave a course inspired, but now teaching, I want to inspire. I know a successful course, webinar, workshop, if one person leaves feeling inspired, I feel like we've done a great job. If 90% of the group leaves feeling inspired, bonus. It's just, and I feel like what we do on Wednesday, we're there to inspire or at least spark an idea, right? It doesn't even have to be full-blown inspiration, but if it sparks one idea on how to follow, one of the best analogies I've heard was, and I forget who said it, instead of pulling people out of the river, we have to go upstream and figure out why they're falling in the first place.
Oh, I like that.
Yes.
Oh,
And this is how I think of what we do now. I get it, it's tight, but why? I get it, it's weak or inhibited, but why?
and you still have to pull them out of the river.
Absolutely.
The figuring out why they're falling in,
Yeah.
brilliant. Absolutely.
And there is a time and a place for all of that. And I think this is an important part for the practitioners that are listening. How I always say it in the sports course is there's a short-term play and a long-term play. So when people are like, where do I start? There's thousands of frequency combinations, there's thousands of assessments. What do I do? The short-term play should always be to get your client or patient out of pain. That is always the short term. It's also the long term, but the short term is how can you decrease pain? And then your long term play is how do we prevent this pain from coming back? How do we get you to manage X, Y, and Z? Because you're not going to cure, fix, erase years of dysfunction or trauma or pain, but you can make a dent in it and then figure out a strategy to manage or sometimes fix and erase if you're lucky. But
And the patient gets up off the table at his 1 or 0, and it's explaining to them that the first rule of bailing out a boat is to stop shooting holes in the bottom of it.
Right.
You aren't allowed to look down. Excuse me? Yeah, you don't bend your head down. How do I play with my phone? It's you lift it up.
Right.
Then my arms hurt, put them on a pillow. It's
Right.
6 weeks. Just, you can do anything for 6 weeks. Keep your neck like this for 6 weeks. And then you don't lift a gallon of milk out at an extended arm. You just keep it close to your body for
Right.
6 weeks. You have a sprained ankle in your neck and
Right.
it will heal. The disc in my neck will heal? Nobody's ever told them that before.
no, we're really good at pointing fingers and labeling things. And not you and I, the healthcare community is a collective. We're really good at slapping labels on things, even if that label makes 0 sense.
Yeah.
Somebody mentioned that they were diagnosed with tight muscle syndrome.
Okay, okay, but okay.
So then I'm trying to like keep this neutral face and trying to keep this.
Oh, you didn't just burst out laughing?
Just no, I didn't. You'd be proud of me. I was able
Extra
to.
points for restraint.
Yeah.
Hilarious.
But I had to say, I used to laugh at frozen shoulder syndrome or piriformis syndrome, anything that had the word syndrome that somebody felt so attached to. And then when you say, a syndrome, anytime you see that word, it's just a collection of symptoms that people put in a bucket because they had to put a label on something. People don't understand that.
And it hurts their feelings because the syndrome at least gave them a hook. They gave them something to attach to.
So this is what I'm wondering. Do people need a label? Do certain people feel better when their pain is labeled?
Maybe. Kevin says it depends on the person.
Sure.
The label helps them get their head around it.
Yeah.
And have a way to describe it so that it's not something that just comes from space.
And I was just saying, I don't want to be hypocritical because I just said we as FSM practitioners sit and listen and help guide people to label sometimes when they have a collection of very vague, sometimes symptoms, and say, you know what, I'm going to pull this down for you and perhaps it's this, right? Maybe you have a vestibular injury. But you're right. I think it depends on the patient, right? And I don't know. I see the value in giving people direction for their symptoms, but where I maybe disagree with it is I don't want you to get caught up with you have this condition or it's
forever. Like you have brown eyes or brown hair or whatever.
right.
Don't get hooked on it.
Right.
And one of the patients, I have pain in I have nerve pain, numbness. I have numbness in my left thigh. And so I put the pinwheel on the right leg, put pinwheel on the left leg. Sensation was completely the same. Yeah, but it feels numb. Okay. Feels as if it should be numb, but it's not. So you can feel the pokey wheel and it's identical both sides. Come look at this diagram. Yeah, that's it. That's right where my leg is numb. That's from the L4-5 and L5-S1 facet.
Yeah.
Oh, okay. They don't mind having arthritis in the facet joints, but this mystery numbness that comes and goes in their thigh really bothered her. Having a cause, lumbar facets, those posterior joints. I said, with your history of falling off horses, falling off motorcycles, falling out of trees, falling on the ice, you have earned the degeneration at L4-5. It's totally, you're good. Now we can go about fixing it. And here's ketoprofen and lidocaine, and you have your MD prescribe it and you rub that on it and you run the FSM unit that you have. Go ahead and run it every night or 2 nights a week or 3 nights a week, anytime this funky left leg goes numb. And so they have a diagnosis, but it's correct. It makes sense. And you have a solution.
Yeah.
So that makes so much more sense than nerve pain in my left thigh or tight muscle syndrome when what you had was abdominal surgery and ureters that are glued to the psoas and kidneys that are glued to the QLs and blood down the femoral plexus so that you can't extend your hips.
Right.
So you do this, and then in 40 minutes, you're like this. And it's, yeah, that's permanent. Yeah, sure.
Right.
Okay, fine.
Even you breaking this down, I think what we're both saying is that we can take super complicated bunches of symptoms and very vague labels that people have slapped upon themselves.
Mhm.
And I love to plan. I love to have short-term plans and big-term plans, and I love all the planning. And so I really feel my calling with the people that I work with is laying out a plan for them. yes, you're in pain. Yes, you were diagnosed with this. Yes, these are your activities. This is the sport that you love. And like you say, it's a management problem, but I think that's what we do with FSM is that take a label, we take a syndrome, we take a collection of symptoms, we help them in the moment, but then we lay out a plan. Like you always say, it's a maintenance problem. We all have maintenance problems. Whether you're 13 and super active and you've got these yummy new baby cells that regenerate and repair in the blink of an eye, or you're 83 and it just takes a little bit more time, it's always a management problem. So I think the best practitioners are the ones that can lay out, okay, this is what we're going to treat right now because this needs to be treated. And this is happening because of this. And then this is how we're going to lay out the big plan later on. And as we change and as we grow and as we heal, that's why your custom cares need updating. So that's my second rant of the week is I came across an athlete a little while ago that had a custom care that was given to him 6 years ago. And it had 20 programs on it. And they were just from the mode bank. And he uses it and he likes it. And I'm like, oh, but this could be so much better. And he's, what do you mean? I'm like, it's if you had an old operating system on your iPhone. It was working, but just imagine if you had all these new apps and it worked faster and it was made for you. So
Yeah, exactly.
that's the point I want to get across.
There's an awful lot of the material that we're exposed to in our training and at workshops and at various places where you learn it and you're done. You have that factoid, and that factoid is not going to change. There may be new factoids that modify it or fit in with it, but you have that factoid. Yeah. FSM has morphed. It's like it morphs every day, where I use torn and broken in the meniscus for the first time in 29 years, torn and broken in the meniscus in the shoulder, and all the shoulder muscles relax and the humeral head glides back. And then I run trauma in the meniscus 214, and all the muscles go slurp. That's a word, right? Slurp. And the patient gets all, wow, dude. And that was the first time in 30 years I'd ever run that combination. So FSM will teach you. So it morphs. It's the same factoids, the same list, but how you think of how to apply it is different.
It's funny. I've had so much mileage treating shoulders, and with the worst patient of all was my daughter because she's my kid, and you can't see things when you're treating family sometimes. So I have a great network of people that can read MRIs for me and break down MRI videos for me, and we couldn't get the pain in her shoulder to go down after she dislocated it. And if there's one thing I know, it's this kid loves FSM and it always works. So what was I missing? So after somebody was going through the MRI, one of the surgeons was breaking it down. So yeah, the pain's probably from the bone marrow edema because it's very painful. And I'm like, bone marrow edema, of course. How did I miss bone marrow edema? I had run torn and broken on everything that could possibly be torn and broken, and nothing was taking the pain down. But the minute we ran bone marrow edema, oh, Mom, thank you. Why did it take you so long to figure this one out?
Was it 40 and 50 with 238?
Yes.
Oh, wow.
I also ran 20, pain and pressure.
Oh, yeah.
Yes, I do love 20. I know it's one that I've really come to love, especially in the joint. I find that it's very helpful. So running it in the capsule, especially in an acute setting. And I've also run it as an emotional frequency when somebody has a lot of pressure on them.
Cool.
Yeah.
All right.
We
I'm
have a question. No, I know it's so funny.
yeah,
Something
can-
shiny in the corner.
but- I should never, I'd never play poker. It's
No,
no poker face.
no, but that's why I like you, because you're real.
Good.
All right. Teresa has a
I
good
got
question.
you.
It's really funny how today I really wanted to talk about, and I'm going to, because the list, I have to at least scratch one thing off the list every single podcast.
I would really like to. I
We're
feel
gonna-
bad about your list.
No, we're going to talk about the adrenals today a little bit, but let's get to, because we're talking about some systemic things and weird things, not weird things, but some vague symptoms with vestibular. And I feel like adrenals need to be discussed a little bit. So let's go to Teresa's question. Via
Okay.
Facebook,
So
that
FSM can be seen as digital or electronic homeopathy. The question is, can a homeopathic remedy such as calc-phos, as George would say, be used concurrently with a vestibular injury? Since I don't know all the characteristics of calc-phos, okay, maybe. Or is the FSM treatment enough on the role of disturbances in calcium and phosphate metabolism and the pathogenesis of hearing loss? There's a lot to unwrap. Number one, vestibular injuries don't always have hearing loss associated with them.
a lot of sport related vestibulars, you will never see hearing.
No, because it doesn't affect the cochlea. The endolymphatic system can affect just the vestibular system if the semicircular canals are wrapped in the endolymphatic sac and the tear is an endolymphatic fistula. It's in one of those little tubes, and the cochlea is undisturbed. So it's a fluid imbalance. I don't know about calcium and phosphate metabolism in the pathogenesis of hearing loss. Okay, I'll take your word for it. If one of the targets of calc-phos is dizziness or disequilibrium, then okay, you can use calc-phos. What I found out about vestibular injuries when I had an episode of hydrops 2 weeks ago was 40 and 44. I know relaxes the neck muscles, quiets down the neck tightness and the disequilibrium. And then 124 torn and broken in the semicircular canals, 44. Combine those two for an hour and a half to 2 hours, and it's hugely powerful. So there's no reason with homeopathy, just in case anybody's wondering, homeopathic remedies have no real stuff in them. There's no real molecule there. So you succuss it and then you dilute it and you succuss it some more. And the more dilute it is, there is no molecule of real stuff. There's just the energy pattern. And you put that liquid on a little sugar pill. And those sugar pills are homeopathic remedies. So it's all energy. It's all resonance. It's all vibrational frequencies. The challenge with homeopathy is the materia medica is like this with tiny print. It's the size of an old-fashioned Bible. And any one remedy can have 20 symptoms that it will address. But there are also another 20 remedies that have that same symptom, but they're combined with other things. Homeopathy is beyond me. It is a lifetime study. Sure, you can use it. It's like asking, can you use FSM while the patient's watching movies on their iPhone? Of course.
Right.
It'll just run right over it.
Yeah.
Or like in the homeopathic formula, vertigo, heal, the remedies calculus, conium, ambra, gracia, and petroleum. Okay, whatever. So you can combine those with FSM, combine them with each other. And I'm not a good client for homeopathy because I won't stop drinking coffee. I drink coffee 1 cup in the morning that happens to have 3 shots of espresso, but that's another conversation.
It fits in a good.
Yeah. And theoretically, with homeopathy, you can't eat peppermint, coffee, caffeine of any sort. And then, yeah, it's with FSM, it doesn't actually matter. So homeopathy, the only one that ever works on me is great. It's been so long since I've used it, I forgot the name. It'll come to me. It's like the magic 8-ball. So there's one remedy that actually works on me, and it's for mood. It's for irritability. Or maybe that's a Bach flower remedy, rock water. That was one of them, but there's a homeopathic remedy. And you just have to work with it and know about it.
Okay.
Louise, last week I asked you about jugular artery. It's actually a jugular vein. The condition is a subclavicular artery web occluding 50%. It's not plaqued. Have you ever heard of web in an artery? It sounds like fibrosis, right? And the subclavicular muscle is this little teeny muscle here. And you have all of the brachial plexus, the brachial artery, subclavicular artery, all going under these muscles, down the arm, and then inside in the chest. Sure, you can run good fibrin entanglement. Yep. I'd use 51 and 62 fibrosis in the artery, scarring in the artery, and go for it. That's part of what I did this week, was scarring in the artery. There's going to be a new slide in the core, and that means there's going to be a new slide in the advanced. And it's about the pec minor. Under the pec minor is the nerve, artery, and vein, and the tendon of the pec minor that attaches to the coracoid.
Mhm.
Take the scarring out of the nerves, scarring out of the arteries, scarring out of the vein, and then treat torn and broken in the tendon, and the whole shoulder drops back. That's pretty cool. And then I love what Derek says, verbal homeopathy.
Ooh. And
Yeah.
Allie wrote school. Please tell more.
Yeah.
What is
So-
verbal homeopathy?
Verbal homeopathy is, wow, this is getting softer. This is amazing. What would you do if you were like out of pain? Can you even imagine? That would be so weird. Wouldn't that be weird? What would you do if you were like, let's pretend this is going to work. And let's pretend, yeah, your pain right now is a 0. Let's pretend it stays a 0. Now, who are you? And
I think you made a very strong statement when we were doing one of the instructor trainings a few years ago, and we were doing a prone practicum. And you said, be very selective with the words that you do. You are assuming this patient is in a state of hypnosis right now. Automatically, right? Especially when a patient is prone. So when they are dwarfed and when they are relaxed, I talk about this almost every episode that we talk together. And it's about creating a safe environment for your patients to be able to unpack the story so that they are telling you what you need to hear in order to fix them, right?
yeah, oh, yes, that's a perfect way to put it.
But you have to have the environment that is there. And that environment goes two ways. You are a listener, first and foremost. Your hands are your eyes. You're there to take in feedback so that you can make an educated hypothesis of how you're going to continue your treatment. However, you have to be very selective with your words back. So saying things like, ew, that's gross, or this is, even though that's what you're feeling and that is absolutely what you are thinking, you don't want to say, oh, this is so messed up. Oh, this isn't.
This is the one I love is the people that have told them, this is the worst I've ever seen.
Right.
I've been in practice 30 years. You've got the worst X.
Right.
Number one, they have the diagnosis wrong. Number two, that X doesn't even actually exist. That's not a thing. Yeah. And so you can say, wow, this must really hurt. No wonder you've been so uncomfortable. This is icky.
It's validating what they are going through without, again, I'm going back to that word label today, without labeling it as something permanent or scary. So I think one of the things that you say, there's nothing you have that scares me or that I haven't, that for me, if somebody would say that, if I had been struggling with pain or a dysfunction or something that I was getting tripped up on, and somebody said, this doesn't scare me, I know exactly what we're going to do. Like right away, I come in from here and I'm like, thank goodness.
Yeah. Exactly.
Yes. And then even if it works or not, at least there's that confidence that it could work.
Yeah. Yeah. At least what I have is familiar to this person.
Right.
It's been a mystery to everybody else I've seen.
Right.
I've been every place, done everything. Nobody knows what's wrong. And it's duh.
Yeah.
This is what's wrong. Okay, let's just move on past the fact that nobody else knew this. I've just done this 400 times. So let's go.
So this kind of is a nice organic segue to the adrenals that I wanted to bring up.
Oh, adrenal.
I feel like this is another diagnoses that people get slapped on them when they are struggling with, especially things like fatigue or low energy or poor digestion. And they're just like, yeah, I'm in adrenal fatigue.
And then you ask, did somebody do salivary hormone testing? No, but it's your adrenals.
So this is my question. This is my first question to you. Diagnosing, that was one of the first things my wonderful functional medicine doctor said is, yeah, there could be all this stuff going on, but salivary hormone testing is going to be the first thing we order to figure this out.
First thing, 4-tube,
Yes.
morning, noon, evening,
Yes.
and night.
Yes. Spit in a tube. That's all you have to do.
Yep.
And is there any other way to diagnose adrenals besides that?
There is a gold standard called some sort of challenge, which is a blood test. And I have always been told that the minute you stick a needle in somebody, their cortisol goes up. So you can't actually measure it in the blood, but they give you a cortisol stimulating hormone, and then they draw blood X number of, and that's the medical standard. But salivary hormone testing is accurate. Other estrogen, progesterone, testosterone do blood levels. The other kinds of hormones are not particularly valid. They all over the map. But salivary cortisol is a thing. You measure that. I came back from Taiwan and I could not sleep. And after 3 months of just going crazy and drugging myself to pieces to try and sleep, I finally did salivary hormone testing. I was in the tank in the morning, normal at noon, high at 5 or 6, and over high, way high at 10 o'clock at night. So I was it's called losing your diurnal rhythm. You're supposed to be high in the morning, low at night. So my good functional medicine, OBGYN, and I was positive for 4 different kinds of mold. But my good functional medicine OBGYN said, okay, you take ashwagandha, sleep through, and nightly restore. There's 2 different versions of ashwagandha that quiet your adrenals at night. And then I decided, when I looked at the salivary hormone testing, I decided to take DHEA in the morning. And some MDs, but not all, will give you a little bit of Cortef, which is hydrocortisone. There's a book that came out in the 50s called The Safe Uses of Hydrocortisone. Hydrocortisone is not steroids. It's not what they give you when you have asthma. Hydrocortisone is the same stuff that you produce in the same dosage.
Right.
It's physiologic. A complete replacement dose. If they took out your adrenals and you didn't have any native cortisol, they would give you 20 milligrams of Cortef in the morning. If your adrenals are just wiped out, then you give you 5 or 10 in the morning, and then 5 at noon, and that wears off. You use it up, because cortisol makes all your other hormones work, right? So you have to have cortisol for thyroid to work. You can't have too much or thyroid doesn't convert, but you have to have some, right? You have to have a baseline of cortisol. So we can treat the adrenals to quiet them at night, raise them in the morning. We know for sure that increasing secretions in the adrenals is time dependent. So you run it for 30 minutes and I got a 22% increase in 30 minutes on a 25-year-old, and I got a 40% increase on a 45-year-old in 30 minutes. Okay, so that means we're driving the adrenals to produce cortisol, but what does that causes the adrenals? Honest to God, I would rather do it with a pill.
Right.
I really would. It's, yes, I can do it. And yes, you can take ashwagandha. And yes, you can just run adrenal support and run increased secretions for 2 minutes and increase vitality for 10 minutes. You can run long COVID fatigue. What? So this, okay, back up. My other pet peeve about fatigue is salivary cortisol you have to do, but on a 40-year-old or 25-year-old, let's say 40-year-old female or male or anybody, you have to rule out sleep apnea, number one, heart disease. What? Yeah, heart disease and long COVID. I had COVID 2 years ago and I've been tired ever since. Okay. Of all the people on the planet, we are the only ones that I know about, besides 35 sessions of hyperbaric oxygen. Don't get me started. Anyway, we have all the 6 virus frequencies, and the virus frequencies in the immune system, the virus frequencies in the vagus, the virus frequencies in the cortex, and why not try the virus frequencies in the adrenals, right? And if I'm not mistaken, the vagus has something to do with the adrenals. So it's, why else would you have fatigue? So I'll do salivary hormone testing, but if that comes back normal, you don't quit. You are still fatigued. We use a watch pat to do sleep studies. I send people to their cardiologist or their GP to get a 6-lead EKG, or if they're 47, they get a 12-lead EKG and make sure that's okay. They get a sleep study, and then you run the COVID frequencies on them. And then what else makes you fatigued? Epstein-Barr. If I had a nickel for everybody that came in and said they had Epstein-Barr, and so does 60% of the population.
I think at least, right? It's, yes. I think it's amazing though how many people get diagnosed with things like adrenal fatigue without any sort of objective findings.
Thank you.
Like that. And so when I ask them what their salivary hormones look like, and they're like, I never had a test. My doctor just said I did.
Yeah, excuse me? How does that work?
And in the mode bank, we have some adrenal programs already set up for people, right? I believe it's quiet adrenals and adrenal support. And I'm not sure if there's other ones that are already on there, but those work great.
They do. And increased secretions in the adrenals is time dependent.
Yeah.
And that pre-workout improved performance that's my job, is to redo the custom care mode bank. Bill Romanowski used that before a game, It increased his cortisol. Bill's already jacked up before a game anyway. So he was Superman for the first half and just crashed and burned in the second half. And so he didn't get to run pre-workout, improved performance after that because his adrenals were doing just fine. Thank you very much.
Right, right.
So it's hormones. I'm not an endocrine guy. It's hormones are like neurology. I like it's linear. You poke here and it goes there and then it goes there and then it crosses and it goes there and then it goes there and then it goes there and it's linear. You follow the path.
That doesn't sound linear at all, but
It is, but at least you can predict where it goes. It goes up the spine and it crosses the T4
Yes.
and it goes up the spine and crosses the medulla and then it goes there and then it goes there and you know where it goes.
Right.
Hormones, you put in walnuts and grapes come out. Like the liver gets to change. Let's see. She produced pregnenolone, but I don't know. I just feel like turning into testosterone. What do you think? I don't know. It could sure. Let's turn it into estrogen. What the heck? Endocrinology makes me a little bit crazy.
I'm glad I'm not alone but like I said, I think we need to do a better job of getting some concrete data for the people that are coming in with adrenal fatigue. There's even an article I think Harvard put out, is adrenal fatigue real? And it was in quotes. So that really, it irritated me because it's but when you read the article, it does just show you that it is a lot of different symptoms that you can't just be comfortable saying, oh, I have adrenal fatigue. Like the fatigue could be coming from so many different sources. It's your job to be the investigator and to ask your primary care or whoever for testing to actually see what's causing it. Your adrenals could be totally fine. Your fatigue could be coming from a chronic infection or from depression or from menopause or then the cortisol would show up. But my point is that I think we do a good job of being investigators, but patients also have to be in charge of their own health too.
Yeah. So I have adrenal fatigue and it's and nobody's done any testing. So what you have is fatigue. Naturopath said, or my acupuncturist said, or worse yet, I have this health psychic that muscle tested me and said, and she's really good. And so I have, all right, so let's test your salivary cortisol.
Right.
And see if it's your adrenals. And then let's look at the other possible causes. I actually did a workshop or presentation on fatigue about 2 or 3 years ago. And it should be on the website someplace. And it looked at the causes that we know about.
Yeah.
And sometimes the cause of fatigue is you expect to work 16 hours a day because you worked 16 hours a day when you were 30 and now you're 52 and you expect still to be able to work 16 hours a day. Right. Let me explain about growth hormone. Being 52 instead of being 30.
Right.
Growth hormone changes.
Yes.
And stuff changes. And it's just, there you go.
Yes.
Oh.
And there you go. It is 4 o'clock.
It is not.
Promise it is.
Oh.
All the alarms going off on this desk are telling me it's 4 o'clock because the alarms are set because it knows we could literally do this for hours.
Yeah, exactly. And when you come in November and do the sports course,
yes.
We'll rent a room at Edgefield and maybe we can have this conversation in the hot tub with everybody that comes to your class.
Everybody, please come to my class so we can turn this into a reality because that sounds amazing.
The hot tub is 3.5 feet long and it's probably half of a city block that winds around a garden that is tropical plants and fountains and
yes, please,
salt water.
Nice.
It's magic.
I want magic.
Come in November.
Nice.
And then we have a 5-day in October And that's filling up, I think, isn't it? And then December is still a long way away.
Sorry.
Oh, Clearfield recommended homeopathic HGH spray. Also works good. So many interesting topics. I think I fell behind as it's past bedtime. Oh, that's Teresa is in Germany. Look forward to meeting you at the October seminar in Portland. Good night. And then Leaf says 1600. Thanks again for your brilliance. Hi, Leaf. Bye, Leaf. Bye, everybody.
Bye. We'll see everybody next week. Same time, same place.
Yeah, and we're going to be in Hawaii in 2 weeks, so everybody get ready for that. Masterclass. I'm sorry. You should come.
Things to do, but
Yeah.
you will. All right. We'll see everybody then.
See you next week.
Bye.
Bye.
The Frequency Specific Microcurrent podcast has been produced by Frequency Specific Seminars for entertainment, educational, and information purposes only. The information and opinion provided in the podcast are not medical advice, do not create any type of doctor-patient relationship, and unless expressly stated, do not reflect the opinions of its affiliates, subsidiaries, or sponsors, or the hosts, or any of the podcast guests or affiliated professional organizations. No person should act or refrain from acting on the basis of the content provided in any podcast without first seeking appropriate medical advice and counseling. No information provided in any podcast should be used as a substitute for personalized medical advice and counseling. FSS expressly disclaims any and all liability relating to any actions taken or not taken based on or any contents of this podcast.